All right, let's go ahead and kick this off. Hello, everyone. Thank you for joining us today. My name is Kennedy McDaniel. I'm the Director of Operations at CANID, and I'm moderating today's event. At CANID, we help pediatric clinics by managing their back office vaccine operations so that you can focus on what matters most, which is, of course, taking care of the kids. Specifically for the COVID-19 vaccine, we're offering a free service where we assist with the vaccine procurement. We provide a scheduling tool that's optimized for handling the COVID vaccine, streamlines documentation and registry filings, and we can even help to enable things like the digital vaccine passports. For any of you who are interested to learn more about our services and specifically what we're offering for the COVID-19 vaccine, which is a free service, we'll be hosting a demo immediately after the webinar. As we all know, the initial COVID-19 vaccine rollout has been rocky. At least it was at first. We've learned a lot of lessons, and that's sort of the good news that brings us here today. As we're preparing for the rollout of the COVID-19 vaccine for adolescents 12 and up, we realized that we have a unique opportunity to connect you to the experts that have been at the front line of combating hesitancy and rolling out the COVID-19 vaccine. I want to make it very clear that all of our panelists are joining us today on their own behalf. No one has been offered any sort of incentive or compensation for appearing here with us today. And today I'm joined by 4 individuals that I'm so excited to get to speak to further and for you to get to hear from. First off, we have Dr. Jesse Hackl. He's been practicing pediatrics for over 40 years, including the last 35 years as the Vice President and COO of Pomona Pediatrics in Pomona, New York. He is also serves as the Vice President of the New York AAP Chapter 3 and serves as the National Chair for the Committee on Practice and Ambulatory Medicine. Something that I think is particularly interesting is he's also the co-author of the AAP Guide on Countering Vaccine Hesitancy. So really excited to hear his perspective on this. We're also being joined by Hayden. Ian works as a Science Communications Manager for the Institute of Protein Design at the University of Washington. But I think what brings him here today is that in spring of 2020, he was a participant in the very first dose-finding trial for the Moderna vaccine. And since that time, he has continued to participate in the Moderna trials and in fact received his 3rd shot as part of the booster trial about a month ago. We're also being joined by Dr. Vik Bakru. He is a practicing physician. Hopefully he'll make it in. It looks like he's running a little late, but he's a practicing physician and the COO CFO of Consejo Sano, which is a multicultural health technology platform that's dedicated to improving quality of care for vulnerable and underserved. He is here. My apologies. So perfect. Quality of care for vulnerable and underserved populations. And I'll get you moved into the panelists. Sorry about that, Vic. And then we're also joined by Ankur Jain. He's the chief architect for Walgreens Digital Health Services. And in order to roll out the COVID-19 vaccine, Walgreens faced many challenges similar to what pediatricians are about to be facing, including unique challenges of the COVID-19 vaccine for scheduling, supply chain, and reporting. Give me just one moment. There we go. You will see Vic appear along with our panelists in just a moment now. You may notice that there's there we go, a slight change from our original plan where we thought that we were going to be joined by Eduardo Fonseca, the former CTO of GoodRx. Unfortunately, he had a conflict and is not able to join us, but we're very grateful to Dr. Vik Bakru of Consejo Sano for joining us today. And Eduardo will be joining us in a future webinar, so keep an eye out for that. Just to give you a heads up on formatting, I'm going to be asking our panelists questions, and I'd like to invite any and all attendees to submit questions that they have in the Q&A as well. That way we can keep this interactive and make this as insightful for you as possible. So I'm going to kick this off with a few questions specifically for Dr. Hackl. We spoke for the first time a few weeks ago, and I think that I was really struck by how you view the role of a pediatrician in the community, and I think it's a perspective that others would love to hear as well. What do you think is the role of a pediatrician for vaccinating your community?
Thank you very much for the opportunity to join, Kennedy. I appreciate this. As a practicing pediatrician, one of the big things that we do is immunize patients. Preventive care and immunizations being a huge part of that is the lifeblood of our practice and the lifeblood of our service to our patients. We're the experts in vaccination because we do it all the time. We do routine vaccinations, and every year we roll out flu vaccine when it becomes available. So we understand both the underlying principles involved, the storage, the handling, the reporting of vaccinations, and we also understand how to ramp up the delivery of vaccines when the flu vaccine becomes available. We did the same thing in 2009 with the new H1N1 flu vaccine at the time, and we're there, we have staff, and we have practices in place, and we're ready to respond whenever it's needed.
That's awesome. I think a lot of the time, of course, as a pediatrician, you've specialized in treating children, but a lot of your communication is really targeted at adults, the parents and caregivers who are making the decisions. Do you feel like there's circumstances where it makes sense to expand the scope of who you treat, and what are the situations that makes sense under?
Sure. Obviously, the conversations we have about vaccines are primarily with the parents. We don't discuss them too often with a 4-month-old. Nor do we give a 5-month-old too much of an opportunity to opt out. So we're discussing the indications for the vaccines, the diseases that we seek to prevent, the potential side effects of the vaccines, and we discuss this every time we administer a vaccine. That's part of the counseling for vaccine administration. And that discussion is primarily with the parents, and when we start to deal with adolescents and older patients, because we do take care of kids through college, we do discuss the same thing with them as well. Because of that, we're familiar with the way that vaccines should be explained to patients of all ages. And the American Academy of Pediatrics came out with a statement about 5 years ago, I believe, encouraging that pediatricians serve as vaccinators for adult patients through their practices as well. And in particular, we administer the flu vaccine to parents of our patients, and we administer the Tdap, the tetanus, diphtheria, and pertussis vaccine to parents as well, should they need it. We have the vaccine, we stock them, we're familiar with the process, and we're willing to do that. And we're supported by the American Academy of Pediatrics in doing that.
That's awesome. How do the parents feel about that? I imagine that's something that could be viewed as kind of a convenience, right? They're already there to have their child taken care of, and now here's your bonus. The whole family is going to get covered with a single visit.
And that's exactly the way we offer it. It is a convenience. I mean, by no means do we push it on parents, and many people come in having already received the vaccines, especially the annual flu vaccine, through other sources. But anytime parents ask, we are certainly willing to step up and vaccinate them.
That's awesome. How have you seen the scope of hesitancy change over time? Right now, there's a lot in the news talking about the record hesitancy we see around COVID-19, but of course, this isn't a new issue or a new challenge. What do you feel like has really shaped the narrative of vaccine hesitancy, and how has that changed over the last 20 years?
Well, hesitancy, as you said, is not a new thing. I mean, if you go back to Edward Jenner in the late 18th century with the smallpox vaccination, hesitancy came about as soon as the vaccine was was developed and offered. In 1905, the Supreme Court in Jacobson versus Massachusetts had to issue a ruling that public health officials were within their rights to mandate public vaccination during an outbreak, again, of smallpox at that time. Jumping forward to the later part of the 20th century, we had the hesitancy that arose about the MMR vaccine, first based on the well-disproven supposed association with autism, the presence of mercury in vaccines, and other, should I say, constructed issues that don't really impact vaccination, yet hesitancy has continued to be with us. We see it today with the COVID vaccine, and it's the same, but it's different. The end result of hesitancy is the same with the COVID vaccine. What we start to hear is that the vaccine is too new. We hear that the vaccine was developed and brought out to market too quickly. And then, of course, we hear the political arguments against it. So hesitancy takes a lot of different guises, yet the end result is the same, with significant numbers of people refusing to get the vaccine at this point.
It's very interesting. One of the sources of hesitancy or comments around hesitancy that I was surprised to hear recently was this concern of genetic modifications, which surprised me a bit, which I understand the Pfizer and Moderna vaccines are mRNA vaccines. It is the first time we've had that. How do you address that kind of concern with patients, particularly when I think it's difficult to discuss genetics in layman's terms in the first place, and probably even more difficult when you're deconstructing misinformation and then trying to rebuild information that's constructive on top of that?
Very true. I think that the descriptions that we've heard about the vaccine as it's been rolled out, the mRNA vaccines as they've been rolled out, has been really very well done by the manufacturers and by the public health authorities recommending them. Yet, when you hear the term RNA, lay people automatically associate that with their internal genetic structure. So what we do is try to put it into as lay terms as possible, describing the difference between the DNA which exists in our cells and which makes mRNA in our cells every day. Because that mRNA is what we use to make all the proteins that our body manufactures. We also indicate that the mRNA in the vaccine doesn't go anywhere near the DNA, and that it is just a messenger, and that's what the M stands for, that tells the cell structure how to create a protein. The mRNA that we know is given in the vaccine is broken down fairly quickly within the body, just as our self-constructed mRNA is broken down fairly quickly and doesn't stick around. So the same processes exist, and we try to very much emphasize that it has no impact whatsoever on our genetic structure and our ability to make other proteins throughout the rest of our lifespan.
I think that explanation is a perfect example of why we need pediatricians to be the frontline communicators about this. And you mentioned something else that I think is very relevant here, which is the concerns that people have about the clinical trial timelines. It's true that in general in life, when you move faster, there's a higher risk of corners being cut. I'm curious what your take on that is and why you're personally comfortable to endorse the vaccine, despite the fact that it was developed much more quickly than we traditionally see.
Sure. I've been around through the development of an awful lot of vaccines, which are now routine in pediatric practice. And it is true that the timeline for the studies, for licensing studies, can often be many years. The difference is that when you structure a trial to determine the effectiveness of a vaccine, you create two groups, the vaccinated group and the unvaccinated control group. And what you're looking for over time is enough data to show that there's a difference in the incidence of disease between the group receiving the vaccine and the group not receiving the vaccine. And if all the disease occurs in the not vaccinated group, when the populations are otherwise comparable, you get the first signal that the vaccine is effective in preventing disease. Now, in some diseases for which we have vaccines, like meningitis, the incidence of the disease is fairly small, maybe 100 or 200 cases nationwide in the course of a year. In order, in your study group, which is obviously not the entire nation, in your study group to have enough cases show up in the unvaccinated group, when you compare it to the vaccinated group, it takes a long time with that low incidence of disease. COVID, on the other hand, unfortunately, we have tens of thousands of cases occurring nationwide every single day. There's lots of disease around. And when you study 30,000 people in a vaccine trial, The half that is unvaccinated is at significant risk of getting the disease in a fairly short period of time. So you start to get a signal that compares the incidence of the COVID disease between the unvaccinated control group and the vaccinated group fairly quickly. And so you can get in the space of 2 to 3 months with a disease with a high incidence, the same amount of data and the same amount of effectiveness signal in those couple of months that would ordinarily take you many years, such as with other vaccines. So it's a unique setting because of the incidence of the disease that we are able to get this data so quickly. And that's not a negative, that's a positive for the vaccine development, because it enables us to roll out an effective vaccine, to do a study that follows all the rules and cuts no corners, and yet to do it quickly and have data that is highly significant, showing the effectiveness of the vaccine on a very short timeline. That's what you need in a pandemic outbreak.
I think that makes a lot of sense. And I think one of your points there really is the two sides, right? There's the fact that there's enough disease in our society to be able to quickly get the statistical relevance that you need, but there's also the fact of willingness to participate in the trials. And I'd love for you to talk to us a little bit about that. And maybe let's start with what led you to decide to participate in the trials yourself.
Sure, yeah. Again, thanks, Kennedy, for organizing and for the invite. So I was a participant in what was the world's first COVID vaccine trial. It was the phase 1 study for Moderna's vaccine, and it started last spring. It started early 2020. This was weeks after this record-breaking development of the vaccine. You know, it was a couple weeks old when I got it, basically. And my phase 1 study, just for those who don't know all the phases or follow this sort of development, phase 1 is just a safety study. It's a very small number of people. It was initially 45 of us in the Seattle area, and that expanded to include Atlanta as well. Tens more people were brought on board. But it's that phase 1 sort of pilot study where you discover the hard question of whether the vaccine causes toxicity, causes issues in somebody that would disqualify it right away. If things look good in phase 1, you can move on to phase 2 with more people, and then phase 3, as was mentioned earlier, in phase 3, that's of course when many thousands of people are getting it, and that's that placebo versus vaccinated group comparison occurs in phase 3. So for me in phase 1, in that small pilot group, I should say up front too, I'm 29 years old. I'm lucky to be in good health. I've never been in a clinical trial before. This is not something I seek out and do all the time or anything like that. It was, a bit of coincidence. It happened to be taking place in Seattle, in the city where I live. I learned about the study from a coworker of mine who posted in our work Slack one day of, hey, I see here that this group is recruiting. They're looking for healthy younger people to take part in this study. You can fill out this form and express interest. So I did that last spring. It's hard to remember, but this was still the before times. So this was Washington State, which at the time was the worst hit state in the country. And our governor was considering whether or not to ban gatherings of more than 250 people. We had fewer than 100 COVID deaths at that time, and we were the worst hit. So this was the earliest days of the pandemic, at least in the US. But it was clear to me at the time, watching the news out of China, watching the news out of Italy, which was a big hotspot then, that this was going to get a lot worse, that there was a pandemic coming. And I saw this opportunity to sign up for a clinical trial, and filling out that form online was easy. I really gave it no thought because I figured I'd sign up, and I didn't expect to hear back, to be totally honest. Surprise, surprise, I did get a call from the clinic pretty shortly after saying, hey, you're the kind of person we're looking for. We'd like to do a physical on you. We'd like to run some blood work to see if you're really the kind of person we want in this study, meaning basically that you have a blank medical history. So for a phase 1 study, they want usually younger patients with no preconditions to discover, that baseline level of safety in a healthy adult. And so that's what I did, and happy to chat more about what that year of that phase 1 trial was like.
Yeah, absolutely. I think you have a very fascinating story of your trial experience as a whole. If you could give us kind of an overview of what your experiences were with the first dose and the second dose in that trial.
Sure. Yeah, so one of the things that's discovered in a phase 1 study is, it's first in man, first in human. So also dosing is established in large part through a phase 1 study. They'll usually give us a lower dose, maybe a medium dose, maybe a high dose, because nobody at that point knows what dose is safe, or certainly what dose is going to be effective, if any. So I was randomly partitioned into the high dose group, and I ended up receiving 2 doses of the vaccine, same dose, but one that is 2.5 times more than what was ultimately approved. So I got 2 shots at 250 micrograms. The approved dose is 100 micrograms, and 25 micrograms was also tested. And so my first shot of 250 micrograms was pretty uneventful. I had some arm pain, like most people get, and really nothing else beyond that. I came back to the clinic 28 days later for dose number 2, and I had quite a rough go of things with that one. It was all the standard symptoms that you're hearing about when people get their second dose, things like a fever, nausea, headache, all that stuff. I had basically all the stuff that we were told to look out for. A fever of 103.2 at its worst. And because I was in a phase 1 study where obviously they're looking for these kind of side effects, I was told to report anything that started to look serious. They wanted to know about it. So we ended up calling their 24-hour hotline to reach a nurse who was part of the study at about 2 or 3 in the morning. I forget exactly when it was. They advised that we go to urgent care. They wanted to look at us and run some tests on me while this was happening, and keep an eye on things. Long story short, basically it was 24 hours of those intense symptoms: a higher fever, nausea, body aches, muscle fatigue, all that sort of stuff. That I went through. It tapered off pretty quickly after I got some rest and drank some fluids. They gave me Tylenol. There really wasn't much else to do at urgent care. I was discharged rather quickly. And after recovering, after that 24 hours of just feeling awful, I've been fine ever since then. It's been a full year since that episode. I've had absolutely no issues since then. Nothing's come up. I've, of course, returned to the clinic numerous times, mostly for blood draws. They want to look at what's happening to my antibody levels, to my immune cells over the course of a year. So I've done all that. I also was asked to do a leukapheresis, a white blood cell donation, which took a couple extra hours to do. And of course, as part of the study, just sort of in general, we've consented to things like genome sequencing and other kinds of secondary research that's being done on us for whatever questions these researchers may want to know, right? Both for the effect of this vaccine, long-term studies on mRNA vaccines. That's all been consented to and is underway.
I think that kind of follow-up after you had those first 2 doses, I think that's something really interesting. And Jesse, maybe you have a thought on this as well, which is that I hear a lot of people saying, oh, there hasn't been enough time to really know that it's safe, right? But I think that there's sort of this conception that you got the shots and then were just sent on your way and nothing else was done except to see if you got COVID or not.
It's interesting. Vaccines are studied in phase 1, 2, and 3, and then there's, after licensing, there's the phase 4, which is the post-marketing surveillance, which goes on for years after a vaccine is licensed. And what we do know is that some side effects, which are uncommon, if they occur with an incidence of 1 in 100,000 and you only study 30,000, they may not show up in the initial phase 3 trials. And that's why phase 4, which studies the incidence of side effects after the vaccine is widely distributed, are so important. What we do know is that the vast majority of reactions to any vaccine are seen within the first 30 to 60 days after vaccination. There are no side effects that occur a year or 2 or 5 or 10 after a vaccine that are directly attributable to the vaccine. And that's been shown with vaccines that have been licensed for a long time and continued, and that have been licensed and eventually withdrawn on the basis of that post-marketing surveillance. So if we don't see a warning signal within the first 30 to 60 days, it is exceptionally unlikely that we would see something coming later. And again, the incidence of the signal, we have given now 150 million doses in the United States alone. That is far more than we would give in the first 10 years of a new meningitis vaccine. So even something that's exceptionally rare is likely to have shown up by the time that we've given those number of doses. And we've done that quickly. So we haven't had to wait that many years. And the data has come in and it's been strong and it's been convincing. And that's why we are so supportive of this COVID vaccine. And it's how we get supportive of any vaccine, frankly, that's newly introduced.
Yeah. And I think something that was so fascinating to me when I was learning more about your experiences, Ian, was that it wasn't just that you had, one of the noted adverse events from that first trial, but you just participated in the booster trial too. And I think that's something really interesting. I'd love to hear sort of how you thought about that decision to go ahead and participate. After your experience after shot number 2, and maybe a little bit about what your experience of shot number 3 was like.
Sure, yeah. So the idea with the boosters, right, I think it's important to say up front, we still don't know if boosters are going to be needed, right? So this is sort of an exploratory study that's going now, and really just out of an abundance of caution. And I was contacted by the folks who conducted my initial study. And I should also say up front, just a note here, that I'm testing the Moderna vaccine, have been for more than a year. I've never spoken to anyone at Moderna. It's not as though they're the ones conducting this study per se. My study is being run through a Kaiser clinic here locally. They're working in conjunction with the NIH, who are the ones who are actually leading this study. So my samples are, I meet with a Kaiser nurse and a Kaiser doctor who specialize in this vaccine testing process. They ship my samples to NIH in Bethesda, and they do the primary analysis on it, just as a note. But so those folks, the Kaiser folks who are running my study, leading the study, contacted me a couple months ago now, maybe 3 months ago now, to let me know that they were working with FDA to possibly modify or add to the initial study that I was taking part in to test this idea of a booster. And they were just giving us a heads up that they may ask us to possibly test the booster if we want in the future. They got approval for that. Moderna was able to reformulate its vaccine. Right now, it's an RNA vaccine that codes for the spike protein from the original coronavirus, the one that emerged in China. They reformulated it. It's an mRNA vaccine that codes for the spike protein from one of the variants of concern, B1351, commonly known as the South African strain, one of the scarier looking ones. So now they had this new version, this new sort of tweaked, like we would update an annual flu vaccine, tweaked for a new strain. And they, of course, needed to test that whether you could give someone a booster. Is it safe to do that? Let alone, is it necessary to do that? So we were asked to officially end our phase 1 study that we were a part of, and on the same moment sign up for a new phase 1 study involving this booster shot. I received a single dose as my booster, so it's not another double dose in this case. And the vaccine that I received is 50 micrograms. It's half of what is approved right now for the Moderna vaccine. And actually the one that I got is a 50-50 mix of what I call Moderna Classic, the original vaccine, and this new South African variant. Literally the two mRNA vaccines were mixed together by the pharmacist who gave me the shot. And in terms of my reaction to that, it seems quite on par with what a lot of people's second dose reaction has been. So after that one dose, I ended up having 24 hours of a very low grade fever, body aches, a bit of fatigue, that sort of stuff that we're all told to be on the lookout for. I stayed hydrated. I played video games on the couch for the most of the day and slept as much as I could. And I was totally fine the next day and have felt great since then.
Yeah, I think that's something that's really valuable, right? If we do find ourselves in a scenario where we're looking to need to administer booster vaccines to the population, a lot of people are likely to have concern that if shot 2 was that much worse than shot 1, oh my goodness, what's shot 3 going to be like? And I think it's really encouraging to hear that, well, actually shot 3 is going to be about the same. But there's a reassurance to that, right? To know that there's not this continued escalation of what the symptoms feel like. I think something else that's really interesting is that element of who you're working with, right? That for you to go in for the trials, there's 2 aspects here. One is that there is a lot of concern from some people about the incentives or motives of the pharmaceutical companies developing the vaccine, right? And I think understanding that the trials are not being necessarily directly conducted by them, that there's really not this opportunity to misrepresent things. I think that's really valuable. But I also think it's really valuable that it is a clinic that's in your community, right? It's not that you were traveling somewhere to do it. Because as we look at the vaccine rollout so far, it's been challenging to reach every community, including some of those that are the most affected. I think this is something that Consejo Sano has really dealt a lot with, right? I mean, this is part of the expertise of what Consejo Sano does, is to really reach these communities and bring healthcare to those who need it most. Dr. Bakru, I would love to hear your thoughts on how we improve access to the COVID vaccine, especially for these communities that need it most.
Yeah, absolutely. It's a great question. In terms of access, we typically define it as, do people have the opportunity or the capability to visit a clinic or to visit with a clinician who can provide them, what they need to achieve better health? And what's missing from that framing is it's not just access. We actually need to couple access with a relationship, right? There needs to be an investment on both sides toward actually adopting whatever health improvement measures we want people to adopt, right? In this case, we're talking about a vaccine against coronavirus, and in other cases, we might be talking about other vaccines, or we might be talking about preventative healthcare measures, cancer screenings, chronic disease management. There's so many categories of care, but we see low uptake in communities that are culturally diverse, underserved, vulnerable populations, predominantly because there isn't a relationship with the healthcare system. So whether or not they have access is absolutely important. We have to make sure that there are brick and mortar clinics and places for people to go, ideally not the emergency room, ideally a primary care environment. But beyond making sure that there's a place to go, what's the experience like? Are they received well, or are they discriminated against? Is the language capability there, or is it hard to communicate once you get there? Are the wheelchair ramps appropriate? Is it accessible by public transportation? And if not, are they waiting outside because they're not allowed in the office right now? And so they take their taxi to the clinic and they use the voucher given to them by a health plan, but they arrive there and they have to wait outside. And in places where it's cold, that's a terrible experience, right? This is actively happening, specifically in the Northeast, specifically with someone I know who runs a clinic who said, what do I do? Do I let people into the waiting room and not have them waiting outside in the cold? Because their taxis arrive in a window of time. We don't have the opportunity to do the Uber Lyft experience of just in time, right? So these are real factors that affect the relationship a patient has with the healthcare system. And so being sensitive to that, being, understanding that, Ian, when you went to your Kaiser clinic, it perhaps was a familiar surrounding. Perhaps it was similar to what you've experienced before, but for many patients in our healthcare system, we must do better. We have to think about health equity in the context of a relationship with the healthcare system. And there are ways that we can achieve that. There are ways that we do achieve it today. We are actively achieving it, but we have to achieve it for all people in our society.
I would add to that that the relationship not only with the healthcare system, but with the individual healthcare provider is very important. We know when we address vaccine hesitancy that a caring and involved physician is probably the strongest influencer of the decision to vaccinate. And so it goes down to a very granular level. It starts with the access to the building, and then it goes down to the granular level of the access to the healthcare provider. It is critically important. Just simply having vaccine does not guarantee access.
Yeah, I couldn't agree more with everything you just said.
Absolutely. So how have you been able to address that, right? I mean, Consejo Sano has been working with the vaccine actively. How have you been able to effectively improve access in that way, and what have the results of those efforts been?
Yeah, absolutely. So I'll take a step back and, for those who may not be familiar with Consejo Sano, it means healthy advice in Spanish. It's a patient engagement platform, and we work in a white label fashion, meaning we work on behalf of health insurance companies and doctors' offices under their banner to build a relationship between them and the healthcare system, between the patients they're serving, and really trying to bridge that gap that exists between patients and the healthcare system. And so when we think about the work that we've done over the last several years, we've gone from about 30,000 patients on contract to over 120 million patients on on contract. And we work with some of the biggest insurance companies out there, Anthem, United Healthcare, Molina, several others are clients that we actively serve today. And much of our work in the COVAX space, and prior to that, the COVID-19 space, was really around education and awareness. How do you take cultural views on healthcare, and we define culture as the attitudes, beliefs, traditions, values, all of the factors that sort of together form the cultural determinants of health. You might be familiar with the sister term, social determinants of health. Well, we really think that there are social determinants to health naturally, but separately, there are also cultural determinants. If your views on healthcare take shape based on your life circumstances, informed by the social determinants, and by how you've accessed or not accessed the healthcare system through the course of your life, you're going to need a different approach, perhaps, than a one-size-fits-all, right? And so our role in the pandemic in particular has been to provide that education and awareness in a culturally relevant context. You can't send out the same English message to everybody. The Vietnamese speaker needs a different approach than someone who speaks Spanish. And it goes beyond the language, right? It's not about taking the English message and translating it. It is about understanding what's the cultural context for the community you're trying to serve. How do you get localized in your approach to be able to bridge that gap? And how do you provide education and awareness and outreach that resonates with, and it's a function of the content. Much of the work we do is by SMS because that's what the communities we serve, 90% of our patients are on Medicaid. And so when we think about how to fit into very complicated lives that they lead, they may work 2 jobs, they might work in an hourly format, they may get 2 10-minute breaks per day. They don't have time to call and make an appointment and be on hold for 20 or 25 minutes with a front office that is likewise overwhelmed with lots of calls. We've got to change and use technology to really help us serve better. And so, you know, many of the results we've been able to drive are around being able to access telehealth. Right. So during the pandemic last summer, over 50,000 appointments that we were able to generate when people didn't feel comfortable and offices didn't feel comfortable hosting patients, you know, within their 4 walls, specifically in the outpatient setting in particular. And so, you know, much of our work is to bring that education and awareness in a culturally relevant context, and then to provide, you know, a new capability that, you know, many of these practices that we serve hadn't before incorporated in the volumes that they were suddenly achieving. And so, you know, aside from the telehealth component to our work with these populations that we serve, with the COVID vaccine, there's been a tremendous amount of hesitancy and work that, you know, we've done in the same, you know, sort of context that Dr. Hackell referenced earlier already, and Ian, the experience you went through, you know, and so much of our effort is to achieve that level of comfort, answer the questions that are top of mind, do it in 25 different cultures. And, you know, we have one of the most diverse call center teams in the country, certainly in the space of digital health. We're so proud of the fact that we come to the table with, you know, folks who have lived experiences that relate to the patients we are serving. That's of key importance when you think about culturally relevant care. And so much of the results we've been able to drive are quantified by the appointments we've scheduled, the engagement rates, the people who have scheduled appointments for the vaccine after interacting, or, you know, a whole host of other metrics that we follow on behalf of our clients at the end of the day.
That's awesome. And Ankur, I noticed you nodding along a few times there. I suspect you have a couple of thoughts and comments here as well.
No, I mean, I think what Vikram mentioned, especially from a cultural perspective, I think the message is different when you're looking at the population, because culturally things are very different, and how you message to different cultures is different because they perceive things differently. So you can't just translate English to their language and be done. That's not how it works.
Yeah, absolutely. And maybe then the question is, you know, this is a difficult thing for even large organizations such as Consejo Sano and Walgreens to tackle. How do individual pediatric practices then figure out how to tackle this? I know Jesse, you've mentioned some thoughts about this to me in the past, but I'm curious to any and all what your thoughts are on how do we help enable individual practices to be able to be at the top of the game for this cultural relevance, to really serve everyone to the best that they can, while also addressing the reality that it's not like there's a bunch of people sitting in these offices with free time on their hands, right? These are already offices full of people that are stretched completely thin, working very hard. How do we bridge this very strong need with this very, very much constrained resources?
It's difficult because, as you say, we don't have staff who are multilingual. We don't have, or as a much smaller operation. And the biggest part about it is to be aware of the issues, to be aware of the cultural difficulties that you may have. Interpretation services are certainly available, and we do rely on them when we have patients where English is not their native language or not their language adequate enough to communicate healthcare information. We're not dealing with 100 different cultures and languages on a daily basis, but our awareness is important. Our awareness of that equity of access is critically important is a big part of it. So we operate within our practice, but we also reach out and are part of the larger community. In our area, we do have many different communities and cultural settings that where people receive their health care. And we try to make ourselves available to work with them on an advisory basis. If there are people in the local community who can handle the language interpretation and we can handle the medical interpretation, you know, you put it together with a phone or a Zoom conference and you make it work. It's not ideal. And I you know, unless I spoke 100 languages, it probably would never be ideal, but it's taking small steps to get there. It's certainly better than we've been in the past, but there's still a pretty long way to go to really ensure good equity of access to everybody who needs our care.
Absolutely. So, you know, we've spent a lot of time thinking about how do we get someone to the point where they know that they want the vaccine. But let's say someone, they're ready to get it and now they want to make their appointment. Ankur, I'd love to hear about how you guys at Walgreens have thought about and figured out how to ensure that you get all of these patients fully vaccinated, especially in a context right now where the vast majority of these individuals will need not one shot, but 2 shots. And it can potentially be very difficult to track and ensure that we get people to that completely vaccinated state.
Yeah, it's certainly been a journey for us at Walgreens. When we started, we opened this up for we started with just dose 1. And some of that was mostly because we ourselves didn't know when we'll get the inventory and will we have inventory for dose 2? Because I mean, things were still being figured out by everyone on how this is going to get distributed. And over time, we have really learned how we're going to get the inventory, how we should be scheduling these appointments for our customers and helping ensure that they get dose 2. So with our latest experience, we are setting up the dose 1 and dose 2 appointments all together to ensure people are setting up their dose 2. You know, they're getting the time for their dose 2 appointments because we did run into situations where people had their dose 1, but guess what? Now they're competing with the same available appointment slots for dose 2 appointments as people trying to get the dose 1 appointment, and it was an issue for us. And so we had to actually open up slots just for dose 2, so people could complete their dose 2 appointments and complete their series. So going forward, I mean, and this is opening up to now. I think 1600 is already up for Pfizer. I think 12 and above is going to open up potentially soon with Pfizer, and I think Johnson & Johnson might be opening up with 15 and above as well. So there's more happening over there. And from our perspective, again, we're trying to create experience and learn from our experience as well as we open these scheduling capabilities of what's helping our customers and what can we do better to help these customers schedule these appointments as quickly as we can offer them, and make sure that they get vaccinated.
And you mentioned something I think that's really interesting, right? That aspect of when you're in this very early stage in particular, there's such high demand that you have people kind of competing with each other to complete their second vaccination or to get their first shot. Although in parts of the country, we're starting to see this taper off as that early demand is decreasing, and we're hitting more of the people that are going to need more one-on-one conversations. But it's about to get back into like this surge state for the pediatric space, right? Because up until now, it's really only been, it's just now that 16 and up are eligible in a number of states. Before that, it was only if there was a health condition. When 12 and up opens up, I think we're going to see a pediatric surge of demand. How do you manage that very high demand, and how would you what do you think would be effective tactics for pediatric practices to be able to implement and manage it as best as they can?
Well, we do hope to see the surge.
Yeah, of course.
Right?
Yes, I agree. It's a good point.
Yeah. I mean, just getting a little technical, I mean, we saw a very high surge in traffic, way beyond what we expected. We have a strong technical team, so we were always testing our system for a much higher load than what we anticipated. And we had to continually do that because we kept on exceeding what we even expected. So it's been tough. We've seen traffics of about in excess of 750 requests per second, which means 750 people coming at the same time within a second to schedule appointments. And when we open appointments, we see a crazy amount of traffic. So think of how things were when the pandemic started and we were all trying to get groceries and scheduling things at Walmart and other places to pick up groceries, right? And the time slots were gone like that. Yeah. And it's the same thing with vaccine appointments. And I think it's more so than what we saw back then, because we've offered hundreds of thousands of slots and they go away within an hour.
Wow. And I know we have a couple of questions. I promise we will get to the questions before the end. There's one other thing that I would love for you to address for us, Ankur, which is, everyone's familiar with the vaccine cards, right? The paper vaccine passport. And I've talked to a number of pediatricians that are like, well, sure, I can do the paper one, that's fine. But there's also this aspect of doing a digital vaccine passport. I know a lot of people personally that would vastly prefer that. The idea of a piece of paper that can get lost or can get damaged or can fall out of a bag, it terrifies them, especially as they anticipate a future where it might be required for certain activities, such as flying to other countries, right? What is, in your opinion, the value of a digital vaccine passport? And why is this something that is worth trying to pursue?
Yeah, so we've been talking to a lot of companies in this space, and we have, as you mentioned, as travel opens up, it's going to become a requirement that you have to show proof of vaccination. And like you said, a physical card will probably be something that people use a lot, but a digital dose card is something which, we're in an age of digital. So it's something that'll make life easier for everyone. When you're traveling, boarding flights, you're using a digital boarding pass. And similarly, if you can scan your proof of vaccination, that makes it easier for you to just, one less thing for you to carry with you. There are airlines that are already working on accepting these digital dose cards. There's a vaccine credential initiative that's been started with a few organizations, which is based on a standard format for how the data should be presented. And it's being done in a way that it is secure. And again, I think a digital format of that is just gonna make life so much more easier for everyone to travel, to visit different events, and one less thing to carry with you.
Absolutely.
New York State has already rolled out what they call the Excelsior passport,
Correct.
which has the added advantage, because all vaccines are reported to the state immunization information system. It has the added advantage of confirming and validating your dose. I hate to say it, but we've heard reports of falsified vaccine cards. And I think that a digital passport will also ensure the veracity of the information. And I think that's really going to be critically important.
Yeah,
it's true. And in these digital dose cards are being done in a way that it is verifiable that you actually got it, that it's actually a signed card. So whoever is reading that information can verify that this is actually the data that was created by whoever provided this. So yeah, it will be verifiable. And again, it's being done in a way that, we can stay away from fraud.
Yeah, I've heard that at least in certain areas, authorities are considering taking into account who is able to issue these digital passports when it comes to allocating the vaccine, as a way to ensure that as many people as possible are using this very high fidelity mechanism for the passport. So I think that's something that's really relevant to keep in mind, especially for independent practices where unfortunately have been waiting and waiting and waiting to actually get vaccine supply. A way to sort of help ensure that your practice is higher up in the list, at least in some areas, is if you can demonstrate that you'll be offering the passport, that can give you some advantage as well. So I see a couple of questions here. I'm going to bring them up just in the order that they were mentioned. So earlier on in the talk, when we were talking about Ian and getting his third shot and the side effects being pretty standard for what most people are seeing for their second dose. We had someone ask, but aren't the reactions to the vaccine age and gender related?
I'm not aware of a huge pattern that has shown, with the exception of the blood clots with the allegedly with the J&J vaccine. And it's only anecdotal, but my experience is that the reactions seem to vary across the board, and I haven't seen a real pattern. Of course, we haven't given it to kids under 16, so it's hard to judge there.
And I was going to say more broadly, in the adult population, we have seen pockets of data that suggest prevalence, higher prevalence in women compared to men with respect to the side effect profile. But it's early, and I would caution us from forming any hard, sort of conclusions at this point in time on what those trends are, because it impacts vaccine hesitancy, and it may not be good data. It might be early data, but it may not be solid or, data that we should use to inform our decision making. So I would encourage, those out there to, take it with a grain of salt, listen to it, of course, tune into it. All data is useful as we make decisions as a society, but be careful that I think we're very early in this process, and we'll learn so much more in the next, the year ahead, because COVID is going to be a part of our lives as we go forward, and so we have to, like the flu, learn how to manage it effectively, and we want to again be making our decisions on the basis of multi-year data, as opposed to regional and small volumes. So got verbose at the end there, sorry, but really
no, it's important information. I think one thing that is also worth pointing out, of course, when we talk about Ian, you're a very real person, but you're one person, so you kind of get into this weird anecdotal, not robust data. But there is something that's very intrinsically true about the fact that you had a certain magnitude of response to your second dose, which was a much higher dose, and a different magnitude of response to the third. And I think that there is something that we can say from that it didn't escalate, right? And we can't say why it didn't escalate, right? We don't have the data for that. But I think that regardless of the fact that you are a young male, there was not that escalation. And I think that's probably worth noting. The next question we had come in, and I apologize in advance, it looks like we have 2 more questions, so we might go just a tiny bit over. I understand if anyone needs to drop off, we will send this recording out afterwards. But this one was targeted to Dr. Hackl, and the request is for you to address the need to space the COVID vaccine from other vaccines that are used in teens, and how you anticipate needing to time it, and how this might impact back to school vaccines.
That's a great question. It's a really important topic, and it's doubly important because one of the things that we found from the beginning of the pandemic is that total number of childhood vaccines delivered plunged at the onset of the pandemic, and we fell behind in vaccinating kids against all sorts of diseases. And we are still trying to make that up and catch kids up. When the COVID vaccine is now available for kids 16 and up, it is important to note that you're not able to receive any other vaccines up in the 2 weeks before, up to the 2 weeks after the COVID vaccine. I mean, that's done out of an abundance of precaution to make sure that any side effects are readily identifiable and readily attributable. And it makes good sense when we're doing something, you know, new and kind of out of the box. So it is going to require extra effort on the part of the patients and especially on the part of the physicians to make sure that nobody falls through the cracks. I saw a late adolescent today who I was about to give a tetanus booster to, and I asked if he had received the COVID vaccine. He said, yeah, I did, and found out that he had received his second dose just 8 days ago, and I removed the order for the tetanus vaccine. I emphasized for him that he needs to come back once that 14-day period has passed, because I don't want him to go unvaccinated against tetanus, but at the same time, I did not want to give it within that 14-day range. So we have recall systems in pediatric practices where we can set that up to automatically recall people who are behind, and you can set up the criteria to do that. We want to make sure that everybody gets everything they need before they start school in September, and it's going to require extra effort on everybody's part, but I'm confident that we will be able to get it done, primarily because we're aware of the need to do so.
Okay. So then we have one last question. It's around this question of booster shots and how we maybe anticipate them being used. I know this is a little bit of a speculative topic. We don't have the data yet, but I think it's a question that a lot of people probably have. Do you foresee booster shots being recommended annually versus biannually? And do you think that they will be focused predominantly on the new strains that might come out? Or do you think that it's going to be more like what Ian received, where you have this mix between the original strain or COVID classic or Moderna classic, that's what it was, which I like that phrase, this blend to reinforce the existing immunity in addition to offering immunity to new strains?
I think it's so early for us to know, but if you're asking for speculation, because that's all this would be, based on the science that I have read and a very general understanding that is not at the level of the experts inside of some of these pharmaceutical companies and certainly in our government, thankfully, you know, the speculation would be that, yes, I mean, I think that you're going to have, like flu, an annual mix that's going to include, you know, tetravalent, quadrivalent. You're going to have, you know, certain strains that are more prevalent than others, and we're going to learn lessons. You know, it's likely going to be a winter-based illness like the flu, and so you're going to see in certain parts of the world that go through winter before we do here in the U.S. What's prevalent, what's common, how much of a predictor is that? We get it 60% of, you know, right some years, and we get it 80% right some other years, and so there'll be sort of this this mixing and matching. But again, it's really just speculation. It's so early to know because we're really just, you know, thanks to folks like Ian, we're just now getting the intelligence around what is it like 12 months out, right? That's now. 12 months out is right now. And we'll get 18 months out. We'll get 24 months out. We'll go through another season together of this pandemic, you know, hopefully not at the levels of infection that we're seeing currently. But, you know, we have so much more learning to do as a global society. And we have to also understand that certain areas of the world are behind where we are in the US, and we're behind certain other areas of the world in terms of the number of surges, first, second, third, fourth, and so on. And so that's going to inform a lot of the exchange of disease across borders, and that's going to inform, therefore, the vaccine mixes that are going to become necessary over time. So so I don't know if I really was able to answer the question definitively, but I feel confident that there really aren't too many people who can answer it definitively right now. It's too early.
Absolutely.
I think, Vikram, that's right. And just as somebody who follows this stuff closely, I work with a lot of immunologists at the University of Washington. I would add too that, it's probably going to come down to a question of these strains specifically and what emerges and how confrontational those strains are, so to speak, because, you know, the analogy with the flu shot is interesting because we don't have to get a flu shot every year because your body runs out of antibodies or forgets how to fight the flu. It's really that different versions of the flu, different strains become dominant and you hadn't gotten protected against them and they're now relevant in your front yard, right? So it remains to be seen with respect to this coronavirus, how dominant these new strains become, how they spread globally. And it is not guaranteed that, you know, we're going to lose the ability to fight, let's say, the Wuhan strain. There's a very good chance actually that you'll have durable immunity against that, both at the antibody level or at the T cell level. There's many aspects to it. So it really remains to be seen, but in that race against concerning strains, concerning variants, that's where the global perspective of the vaccination becomes so important, because, you know, as long as the virus is infecting millions of people and it has an opportunity to mutate, that's where those new concerning strains come from. So it becomes a global problem that affects everyone, you know, in their own backyards.
And it's also a problem that hesitancy impacts. If we could instantly vaccinate everybody, the virus would no longer have a host and we could wipe this out. And so getting as many people vaccinated as quickly as possible is going to be a major, major issue, which is why we try to address hesitancy every step of the way.
Absolutely. Thank you so much. I'd like to give a special thank you to our panelists for joining us today. Really insightful and really helpful information. I know I've really enjoyed the past hour speaking with each of you. And of course, thank you to our attendees for coming, for having questions, and I think really great questions about it. As a reminder, anyone who is interested in learning more about Candid services and how it works, including enabling issuing vaccine passports, being able to schedule the visits without disrupting your regular practice operations, and just handling that standard back office, frankly, headache of inventory documentation and registry filings. We will be staying on for an extra 10 minutes. Alternatively, I will be following up with everyone afterwards with a link if you would like to schedule a time to speak later. And I will also include a link to this recording. Thank you, everyone, again, and I hope everyone has a wonderful afternoon.
Thank you.
Thank you very much.
Thank you, everybody.
All right, and my colleague Pedro is rejoining us now as a panelist. He will be giving us a walkthrough of our services and answer any questions that you have specifically about Candid. Perfect timing.
Hello.
Hello.
It's a very insightful conversation. I loved it.
Yeah, I learned quite a lot. I'm very excited about it.
Awesome. So thank you all for staying here a few extra minutes, and I think you know, part of the reason why we wanted to talk about what Candid is doing is because we realize that, you know, as we talk through a lot of these challenges that pediatric practices might be, that it might be pretty hard to think about kind of what the last year has been like in terms of the changes of your practice and the challenges that you've gone through over the last year, and then come up with a strategy for this new challenge that's coming up, right? And you know, in many ways, we've thought about Candid as a way for us to help smoothen that bumpy road that you've already been through, but are likely going to be a part of in this next in these next few months, or probably longer, actually. So anyway, as we think about that challenge, you know, we as a core product, as Kennedy mentioned, we are very much focused in the management of pediatric vaccines. That's not what I'm going to talk about right now, although we're happy to talk about that later if that makes sense. But really, the way in which we are approaching this pandemic challenge is really around, you know, reframing our software in a way that we can actually give for free the support that we give to our practices with pediatric vaccines, specifically for the COVID vaccine. And you know, as part of our central motto, the way in which we approach that is by saying, look, we want you to focus on taking care of the patient while we take care of the rest, right? And operationally, what that means is really a full stack suite of things, right? We essentially, for starters, our goal is to get you the vaccine that you need, and we've seen a lot of challenges with that, right? So, as some of the people that we just heard about mentioned, the supply has been limited, and the challenges of getting it as a small practice have been high. In fact, at least in some areas, we're seeing almost zero vaccine being given out to smaller practices. So our first goal helping you out here would be to get you the vaccine that you need, right? And as we do that, really what's been most important is in helping us unify as a pediatric community and say, we need to be proactive about working with the state authorities and basically like bringing in the group that would be significant enough that we can actually distribute and give enough shots in arms for us to get a seat at the table with the states and the authorities that are in the distribution of the vaccine, right? And so that's really the first step in which we would help you set yourself up. Now, the second thing is really, helping you with the operations of running this vaccination program. And that means making sure that you've got the inventory. That means, as we heard about from scheduling, making sure that you're able to schedule the tens of hundreds of people that might come to your practice at a given time. And that you're not leaving anybody out because your phones are overloaded and that sort of thing. But also being able to help you structure around the 10-dose requirement. Basically, what I mean by that is that for every vaccine vial, 10 shots are given. And so we would help you structure your schedule so that you can actually achieve that. And then on the other side, there's a reporting component, right? Every time, just like you do with your pediatric vaccines today, there's requirements of the IIS, of the immunization registries, that you need to be reporting that vaccine. That can be manual. There's also additional reporting components to the COVID vaccine itself. And so one of the things that we do is we'll set you up with a scanner that will allow you to associate a patient automatically to the vaccine that was given so that we can report that information for you. And that's not something that you need to worry about or do at the end of the day or work with your EHR to figure out how to actually get that information to the right place. More importantly, we don't want to have anybody angry at you for not reporting or anything like that, right? So that's a very big part of how we also help out. And I do want to show you there a little bit about how that works more in practice in a minute. And then the final part is really kind of closing the loop with people. We talked a little bit about, making sure that you get first vaccines and then second vaccines. But it's also about billing, right? And part of this is it's important that you get the reimbursements that you need. Those billing requirements have changed and are likely going to be somewhat of a variable as we learn and as we do more things around this. And so, we want to be your partner in the reimbursement model as well, and help you set up your billing so that when you're submitting a bill, you're not getting rejected by insurance companies, that we're verifying the insurance as you go through the process and not afterwards or anything like that would cause any confusion or problems down the line, making it as seamless as possible for your team internally and your staff, as well as the patient, right? As you all probably know at this point, the vaccine is completely free for people, but we do want to make sure that the insurance companies have the information that they need to pay in the right way as we go through this, right? So without further ado, I want to jump in here for a few seconds and just give you a very, very brief demo of how our internal software works. Now, there are other components that we are currently working on releasing, and we'll be doing so over the next month or so as we get to the release of the COVID vaccine for children. But this is one that I really wanted to show you because it's really what your internal team will be using if you use Candid. So, Kennedy, can you confirm that my screen is showing right now?
Your screen is showing.
Awesome. So the first thing that you'll notice here is the list of patients that you have for the day. And I want you to think about this for a second from the patient's perspective. For the patient, basically what they do is they go to a website and they are able to see the appointments that are available in your practice, right? And when they do that, they schedule a time, they automatically get assigned a second time as well for their second dose of vaccine. And that information gets pulled right into this dashboard, which is your central dashboard on a daily basis on how you check what's going on in your practice today. Now, this can be accessed through any computer, any phone, anything you want. It's all cloud-based, obviously, very secure and HIPAA compliant. And so what we do is essentially, let's say that we have little Johnny here, who we are serving today, we would be able to see their information and simply pick that person, right? Now, the second step of this process is really around insurance verification. We want to make sure that we have the insurance on file. And if we do not, that we have, we prompt that question. And then we can verify the status if needed. Obviously, if there is no insurance or there's any sort of other issue, then that goes through the VFC program, which should be fine. We just need to know what the actual case is. And then you can also verify the validity of any previous insurance information that you may have directly on the system without having to go through any additional hoops. And then you go into the scanning part. Now, the scanning part is essentially, we would set you up with a scanner that would allow you to basically upload all the information that you have from the vaccine to the computer without any sort of manual typing, right? Everything from lot number, expiration date, NDC number, etc. That all gets uploaded. And of course, this is a demo, so we don't have the scanner here, but essentially it would work very similarly to what you might see at a grocery store, or maybe even if you've seen it at a hospital. Hospitals do this all the time. Ultimately, you would upload this information to our internal system. Now, this information contains the expiration date, lot number, any other IDs that are necessary to be uploaded. And as those get uploaded into our database, what we do from there is we make sure that all of the right databases are being updated in the right way. So one is your electronic health record system. We want to make sure that you have the record that you gave this vaccine to this person. The second is your the IIS system that you work with. So we are connected directly to those IIS systems, and we're able to upload that information so that they can also, by the way, asterisk there, retrieve their vaccination passport later, but also, we also have that information being submitted on your behalf, so you don't have to worry about that. And then finally, the submission of the bill itself, right? And making sure that when the bill is given, you are also given the information that is needed of the vaccine that's given. And then that's really it. That's the process that you would go through with everybody that you're giving a vaccine to. Of course, this one is specifically focused around pediatric vaccines, but our COVID module is more around the COVID vaccine itself. Very similar process, however, and something that's, our goal is to make it as easy as possible for you to go through the process quickly without actually having to deal with all the typing and all the challenges of figuring out what to do next. One thing that I also didn't mention is that as you scan these vaccines, we can also keep track of your inventory. So as you're running out of inventory, we know that that's happening, and we can understand that you'll need more, right? And we can then go talk to the state or whomever is the provider of the vaccine. In the COVID vaccine, it would be the state, right? And help you make sure that you get your next batch at the right time, so that you're not running behind or having any issues with that. So that's a very brief overview of what we're doing. One thing that I also want to emphasize is that when it comes to the COVID vaccine, our products are completely free and very easy for you to sign up for. Part of the reason why we're doing this is because we believe that we should speed up the COVID vaccine as much as possible, as Dr. Hackl said. Also, obviously, we do have a vaccination product that's a little bit more holistic, and would love to speak to you about helping out with all of your vaccines as well, if that's something that would be interesting to you.
So someone just asked a question, Pedro. So Andrew Schumann is in New Hampshire. They have state supplied vaccine there. And he's wondering if they can use this system, and if so, how expensive is it?
I assume, Andrew, that you're talking about all vaccines, you're talking about pediatric vaccines being state supplied, right? Just to be clear.
Yes.
That's correct, yeah. So for now, we have not yet expanded to state supplied vaccine states. And there is no reason as to why we shouldn't be able to in the future. But it actually doesn't have anything to do with our ability to take that on. It's just a matter of really being lockstep on how we expand, right? We are still a small team and very focused in particular geographies, but obviously would love to serve New Hampshire over time, and we want to make sure that we do that for state supplied vaccine states as we go. We don't expect, once we do expand, it's hard to say at this point, but we wouldn't expect it to be expensive for you. And in fact, like, what we want to do as a maybe general philosophy is to make sure that we don't cost practices additional dollars. We know how challenging it can be to make ends meet when it comes to pediatrics. And so in many cases, what we do as a philosophy is we want to negotiate and work with the manufacturers and the insurance companies to get our margins, and not pediatric practices, right? So we would help you set yourself up, streamline everything, and then we would work with the payers and the manufacturers to ensure that we actually get a little bit of the share there and we can make a scalable business here on our end. But we want to keep our interests aligned with our pediatric practices as much as possible. In terms of New Hampshire, it's really hard to say for me right now. I would say, yeah, I would love to keep in touch with you, and we can keep talking, and we can put you on a list and let you know when we're available in New Hampshire. It's really hard to say for us at the moment. We hope it's very quick. But I wouldn't want to overpromise there.
Awesome. Yeah, one thing that I'll just add in quickly there, kind of around those last points about how we operate as a business and what our mission is. I do think it's really important to note that the ethos that really drives us as individuals working together on this team is the value of having these independent clinics, and the importance of understanding just how strained and constrained the resources can be. And so we're very sensitive to that, and wanting to ensure that we don't tell you that we're alleviating a burden to only create another burden instead. And so for us, it's extremely important to really know that we're able to solve this problem for you, as Pedro said, in a way that's incentive aligned, where it's not just that we save you time, but then cost you a lot of money. It needs to be that we truly improve your practice's ability to not merely survive, but to thrive, because we know that that is when communities are best served, and that's when doctors are able to do their job best. Awesome.
Thank you.
No, thank you so much for that, Pedro. It was awesome. Thank you everyone again for attending today. If you have any other questions, please feel free to reach out to us. As I said, you'll all be getting a message from me shortly as well. And I hope everyone has a wonderful rest of their afternoon.